Hello, welcome again to another edition of Matters of the Heart. I'm Seth Bilazarian, a clinical and interventional cardiologist with Pentucket Medical, and this program is brought to you by Haverhill Community Television and Pentucket Medical Cardiology. Today I'm with my associate, Dr. Sunny Srivastava, to talk about a common medical problem, a common cardiologic problem. Actually, it's the second most common reason why people are admitted to the hospital in our area, and that problem is called atrial fibrillation. So, Dr. Sunny, tell me what you know about this.
Yeah, so thank you for having me, and hopefully this can be of some use, because again, like you said, it is one of the most common reasons for people to come to the doctor or the emergency room, certainly. So atrial fibrillation is a heart rhythm problem. So what does that mean? The heart has four chambers, really. There are two upper chambers that are called atria, and two lower chambers called ventricles. And these chambers are managed by an electrical system that tells it when to beat, almost like wires, electrical wires. And the upper chamber has a little area that generates the electrical impulse to tell it when to beat, and then the impulses travel down to the rest of the heart. And what can happen in atrial fibrillation is that this system can go haywire or run amok, where the electrical impulses in the upper chambers, the atria, they start firing out of control and erratically. And they, as a result, cause the heart to beat irregularly, and can also cause it to beat rapidly, as it tells the lower chambers to beat quickly as well. So it can be a real problem for a lot of reasons. One is that it can cause one to feel uncomfortable, or the sensation that their heart is racing, palpitations. Some people don't feel anything as well. And there are a lot of other consequences and sequelae that we'll certainly talk about as we go on in the discussion.
Okay, great. So you said it was common. So can you tell us about some things about why it happens, some causes for this problem?
Yeah, sure. Well, I said it was common. What does that mean? So it's anywhere, different statistics will say anywhere between 2.5 to 3.5 million Americans have atrial fibrillation. So that's a lot, no doubt about it. And it becomes much more prevalent as we age. But what are the causes? So we see this every day, so we try to figure out what the causes are. Some of the more common causes are if you have underlying structural heart abnormalities. So what does that mean? So if your heart is enlarged, or if it's weak, or if the valves are leaky, or the valves are narrow and don't open as well. Those are things that can really lead to atrial fibrillation. If you have high blood pressure that's not well treated, if you have other heart problems such as coronary artery disease or prior heart attacks, these are things that we think of that could be contributory. There are more rare things where you could have congenital heart abnormalities that could lead to it. Other things such as overactive thyroid, which is a common condition, can sometimes cause it or lead to it. Stimulants or exposure to stimulants, so caffeine, interestingly alcohol, binge drinking, that type of thing can also lead to atrial fibrillation. Cocaine is another type of thing that people think about. People with chronic lung disease, so if you have something that's called emphysema or COPD, it's thought that that can trigger atrial fibrillation. Sleep apnea as well. Or if you're just ill from something else, critical illness, if you're hospitalized with a severe pneumonia or an operation and you're doing poorly afterwards, that type of severe critical illness can also trigger atrial fibrillation.
Okay. So there's a lot of common things can cause this common problem. Mm-hmm. So how does it show up? Like, what do people have for signs or symptoms of this problem?
Right. Often, I should say, people feel nothing, and that's actually sometimes makes it more difficult to deal with because you don't know it's there, you don't pick up on it, because there are some reasons why you want to know about it. But the other things that people can feel, something simple as palpitations, a sense that your heart is beating irregularly or quickly as well. Some people have much more subtle things, such as just weakness, fatigue, malaise, just feeling sluggish. Some may be lightheaded or dizzy. Sometimes it can be even more subtle than that, just confusion. You can have chest pain, you can have shortness of breath. So those are the type of things people sometimes might have. Also, might have fluid retention as a subtle way of picking up on this, that the legs may get swollen, the belly may get swollen with fluid, the lungs, and so you're short of breath. So those are some of the more common symptoms people have.
So is this something that comes and goes, or what's the story with that? Or do you have it all the time, or how does that work?
It varies. So in some people, it can happen now and then, and that's a sporadic finding, and that's known as what we call it paroxysmal atrial fibrillation, comes and goes. Some people it can be persistent or chronic. And so it varies from person to person, and whether one is symptomatic obviously varies from person to person as well. And those things really dictate how we treat people, whether somebody is symptomatic, whether there's other features that one has, if it's persistent or sporadic. Those are other features that really play a role in how we treat people.
Okay, so how does it get picked up? How's the diagnosis made?
So in the setting of, for example, somebody having no complaints, not noticing it, that's usually picked up upon when someone goes for their routine physical exam, annual physical, for example, and their physician will listen to their heart and pick up on the fact that it's beating irregularly. Often leads to an EKG. An EKG is a test where people have electrodes put on their chest, and a one-page tracing is printed out documenting the electrical activity of the heart. And there are characteristic things we see that can tell us if it's atrial fibrillation or a normal rhythm. So that's somebody who's not feeling it or asymptomatic, that someone else has to pick up on it then.
But you highlighted the irregular part. So really, that's sort of the key thing here. So if someone listens to your heart and it's irregular, or how about other ways to sense the heart's pulse in finding
Yeah, so if you
irregular?
feel your pulse, certainly too. So you can feel your pulse here in the wrist or here in the carotid arteries. Those are ways to
So
feel your
someone
pulse.
could do this themselves, and they say that instead of having a nice regular heartbeat,
Right,
that if it sort of had some kind of irregularity, there wasn't a sort of metronome kind of regularity to it, they should suspect that they might have this. Is that correct?
Well, and that might be overstating it a little bit because
Okay.
there are lots of other types of irregularity when one feels your pulse. One can have something very simple as extra beats or premature ventricular contractions. These are something that are generally very benign. It can cause irregularity to the pulse, so it's a little trickier than just saying if it's irregular you have atrial fibrillation. And that's probably a disservice for me to convey that message, certainly.
But if someone felt that their heart was irregular, or a nurse felt someone's heart, at a workplace and was irregular, would that warrant some kind of evaluation?
Yeah, absolutely. And start off simply by going to see your primary care physician, that they can listen to the heart and do an EKG, and if more testing is warranted, then more testing gets done. So what are some of those tests? So we can sometimes have people wear monitors. There's a type of monitor that's called a Holter monitor. You wear it for 24 hours or 48 hours, and it's a continuous recording of your heart rate, your heart rhythm, and it's a nice way for us to pick up on whether or not one is having atrial fibrillation or other arrhythmia problems. There's another type of monitor that's called an event monitor. People often wear these for 2 weeks, for example. This is a little different. This is a monitor that's triggered by the patient. So if you feel something, you press a button on the monitor, and it gets sent to the physician. And that's also a nice type of monitor that people have. Now let's say you have your physician picked up on atrial fibrillation. What else gets done? So you've done the EKG, maybe you've worn a monitor. We often check different types of blood tests. The specific blood tests, often we look at thyroid function is one we often look at to make sure your thyroid is not overactive, for example. But just general, make sure your blood counts are normal, you're not anemic, your electrolytes, sodium, potassium, magnesium, these types of things, make sure they're all in order. But then we often do something that's called an echocardiogram. That's an ultrasound of your heart, where some gel is applied to a ultrasound probe, put on your chest, and it allows us to take pictures of the heart to make sure it's structurally normal, because that's an important thing for us to know about. If there are structural heart abnormalities contributing to the atrial fibrillation, you get treated a different way often. So those are, I think, some of the initial basic tests one would do. Now, if somebody was complaining about chest pain, for example, perhaps you might undergo a stress test as well, which I didn't really mention.
Okay. So you say that, just to summarize, I think what I hear you say is that if someone has some irregularity, they might have atrial fibrillation, and it can be pretty easily diagnosed by a primary care doctor or a cardiologist. And it's a basic test to try to figure out why they're having it.
Yeah, I say easily, although I should caution that sometimes it's so sporadic and so intermittent that it can become difficult sometimes, that you can wear these prolonged monitors and miss it and such. So that possibility certainly exists.
But that's less frequent.
Yeah, absolutely.
Usually you can pick it
With
up.
atrial fibrillation, that's less frequent of a problem.
All right. So then you find out you have it. So what? Why does that matter to me? Why do I care?
Right. So especially for the people who have no symptoms with it, they'll often say, well, so what? I don't care. And it is a big deal that when the atria, the upper chambers of the heart, are beating irregularly and chaotically, they are no longer contracting nice and rhythmically. So instead of a nice contraction like this, they're fibrillating, doing this. And when they're fibrillating, blood can pool, become stagnant, and when blood becomes stagnant, it can often form a clot. And if a clot forms in the heart, that obviously doesn't sound so good, but the big issue there is that a little piece can break off of that clot and travel elsewhere into the body, the most concerning place being the head, where it can cause a stroke. And it can also travel elsewhere, into the legs, the hands, the kidneys, can cause different places, it can cause problems. But the one we really talk about the most with people, I think, is the head. And it can cause a stroke, and naturally that's a big concern because stroke is obviously can be a potentially devastating thing to happen.
Well, just to be clear, so a very tiny piece of clot could go anywhere in the body, and it's not that we don't care about the kidney or the liver or something else, but if you had a little tiny clot go to the kidney and you lost a little part of your kidney, you probably would never know about it.
Probably, although if massive amounts go there, or if you already have underlying kidney disease, that little hit could be...
Right. But what I guess what I was trying to say is that the reason why the brain is so important is it's an important organ, and maybe it's a little more important than other parts, but all of our organs are important. Right. But a small injury to any other organ is not as devastating as a small injury, because if it hits the right part of the heart or the right part of the brain, or I should say the wrong part of the brain, you could lose your speech or you could become paralyzed. Right. So the problem is the brain is because it's so sensitive to a small injury.
Right, absolutely. And it's also much more likely just anatomically for these things to travel to the brain, given that the major arteries feeding the brain are right there when blood comes out of the heart. So it's a potentially life-altering thing to happen, and so it is a big deal whether one feels the atrial fibrillation or not. There are different ways we assess one's level of risk for developing clots or developing stroke. For example, if one has had a prior history of congestive heart failure, that may increase your risk a little bit. And congestive heart failure is fluid retention. If one has had a history of high blood pressure, if one is over the age of 75, if one has diabetes, if one has had a prior stroke or what we call a TIA or a mini stroke, all these things contribute to your risk. And there's a scoring system that we often go through in our heads to assess one's level of risk. The more of those things you have, the higher your risk is, and the more likely you would benefit from a certain type of treatment. That certain type of treatment is a blood thinner right now called Coumadin or warfarin. It's commonly prescribed. I'm sure many of the viewers are aware of it, and it can be a nuisance to take it, no doubt about it. It requires frequent blood tests for monitoring to make sure your blood is not too thin or under-thinned, or too thick, I guess is another way of saying that. But the benefits outweigh the risks, certainly, with prevention of stroke in certain people, in the right patient type. So that is one arm of treatment, is the prevention of stroke. Absolutely one very important part of the treatment. So you asked me, why do we care? What are the complications? So one is stroke, and that's the biggest one to talk about with people. But there are other things that one may have the propensity for a rapid heartbeat in atrial fibrillation. And if the heartbeat, or rate, I should say, is left uncontrolled and left to go fast, that can put a strain on the heart. It can lead to something called congestive heart failure, or even cardiomyopathy, a weakening of the heart muscle. So that's important as well. So those are the main, I think, things we think about as far as complications of atrial fibrillation.
Okay. So let me just summarize. So the big one we worry about, you said, was the clot forming, clot going somewhere, and we worry about the clot going to the brain causes stroke. And the way that's treated is to thin the blood with that medicine called Coumadin. And doctors decide whether the patient needs it based on some risk factors that you described.
Yep.
And then the second thing you said was that the heart can go very fast, so we try to control the speed by using medicine to slow it down. Are there any other treatments that are used for this problem?
Yeah, so there are a lot of different treatments. So it's a little bit of a complicated discussion because it really has to be tailored to each individual patient. So if one is symptomatic, now if one is symptomatic when their heart's going fast, but when it's slow and back in a normal rate, they feel fine, then you use a certain type of medication to just keep the heart rate slowed down. Some of these medications that are commonly used are called beta blockers. So some of those names are atenolol, metoprolol, Toprol, Lopressor. Those are some of the more common names. Carvedilol is another name. You use those, or calcium channel blockers, so diltiazem, cardizem, verapamil. Another class of medication, digoxin. So those medications are often used to slow the heart rate down. And once the heart rate is slow and the patient feels better, great. But you also are treating them simultaneously, often with this blood thinner, Coumadin. Now, some people, no matter what the heart rate is, they still feel lousy in atrial fibrillation. They may be sluggish, they may be tired, fatigued, short of breath, chest pain, a lot of different types of things. So those are some people in whom you may not want to just slow down the heart rate, but you may also want to try to convert them back to a normal heart rhythm to get them out of the atrial fibrillation. It doesn't necessarily get rid of the need for Coumadin, but you're trying to fix their symptoms. So you're still giving them Coumadin to thin their blood often. And there are different ways to convert people back to a normal rhythm. There are medications, some of which have some side effects that are pretty significant, which is why we don't often just jump to using these medications. But there are medications that are used to help convert people back to a normal rhythm. And if that doesn't work, there are procedures that can be done, certainly. One common procedure is called a cardioversion. And what a cardioversion is sort of like what you see on TV, or one sees on TV, are paddles to the chest. Now, it's not like on TV in the throes of an emergency where people are rubbing the paddles together and zapping you. It's done in a controlled fashion with anesthesiology, make you sleepy, and paddles are applied to the chest with electrical current delivered, and it can shock you back into a normal rhythm. Doesn't always work, as many of our patients can attest to, that, for example, if the atrial fibrillation's been there for a long period of time, or if there are severe structural heart abnormalities, it may not work in getting you back. Those are some of the more standard, I think, first-line treatments of choice.
Okay. Are there any other treatments other than what you described were medication treatments and the cardioversion treatment, which is the shock? Are there anything else that we should know
so
about?
There's some other things that can be done as well. For a while now, we've done a procedure that's called an AV node ablation. The AV node is a specialized bit of tissue in the heart that helps control the heart rate. And in people in whom the heart rate's been difficult to control, you can just go into the heart with catheters. It's a minimally invasive procedure, and you can essentially, for lack of a better phrase, cauterize or zap that AV node and knock it out. Controls the heart rate, but a pacemaker needs to be put in that situation as well, so that you can still maintain a normal heart rate. And this again doesn't get rid of the need for Coumadin. The atria are still fibrillating, the upper chambers of the heart. We have now just created a situation where the lower chambers of the heart can't take off and go rapid. And it's actually a useful treatment for a lot of people. It's well tolerated, and both of us have plenty of patients who've had this done. We, in the field of cardiology, have developed other procedures now that are perhaps slightly more risky than that AV node ablation. There are other types of ablations called atrial fibrillation ablations that are done, where a catheter is put up to the heart, often from the groin, and get up to the heart. And when they're in the heart, the catheter has to poke a hole within the heart to get to the left side of the heart. So that carries with it some risk. But when they get in there, they can map out where the atrial fibrillation is coming from. And it's often right around the pulmonary veins. These are veins that are bringing blood back to the heart. And you can go in there and you can, again, just zap that area, cauterize it. And it can be successful for certain types of patients, but again, it's not without risk. It's not something that we jump to up front because, number one, it's invasive. Number two, there's some risks involved with it. And number three, if one can be maintained on medicines, that's a much better option, certainly. But the atrial fibrillation, or AF ablation, is certainly a important procedure, one that's, I think, becoming perfected more and more. It's a relatively new procedure. So
how would you quote the success rate of that procedure currently, if you were to refer
Yeah,
that
and it varies from person to person. I have to admit that I'm not up to date on the latest statistics at the centers, for example, that are doing it all the time. It varies from center to center, certainly, with one's level of experience. But what are the last statistics you've seen?
I mean, it seems like it's around 60.
I was going to say 50 to 60 in some places.
Somewhere around that. And most patients, seems to me, have to have 2 of these long procedures. Yeah. They last 3 or 4 hours. So I think you said it very well, that it's in the evolutionary process for someone who's severely limited and couldn't tolerate medicine. It's worth discussing it, but it's not ready for prime time.
Yeah, it's certainly not the need. I have plenty of people who ask me right off the bat, they have one episode of atrial fibrillation, and they don't like taking Coumadin. That's the real thing for them that they don't want to do. So they say, well, can I have one of those ablations? The ablation is, to get off of Coumadin, no one would recommend doing an ablation for that reason. And it also doesn't necessarily get rid of the need to be on Coumadin, because
Right.
these are not always curative, as you just talked about. And it's really something that's reserved for people who are very symptomatic despite the use of medications,
Okay.
and certain types of medications.
Are there any other procedures that you should mention that, sometimes you mentioned went from less invasive like medications to a little riskier medications that keep people in normal rhythm, to pacemaker type treatments with AV nodal ablation, to newer treatments like atrial fibrillation ablation.
Yeah.
So is there anything else that you
Yeah,
want to
there
highlight?
are. And actually, one more thing about the atrial fibrillation ablation that I want to mention, that there are other types of ablations for other types of heart rhythm problems. They're not quite as complicated or as difficult to do. So something called atrial flutter, which is like a cousin of atrial fibrillation, is actually much more amenable to ablation and does much better. It's much easier to perform. So that's something where we might send someone to a flutter ablation much more quickly. Okay. There are other types of heart rhythm problems called supraventricular tachycardias, or SVTs. Those are also usually much more amenable to ablation, and they're not as high risk of an ablation procedure. So I just want to make it clear that there are different types of ablations out there. But your question about other procedures, and the answer is yes. There are surgical procedures as well that can be done. Obviously, those are quite invasive. Often when one is undergoing, let's say, bypass surgery or valve replacement surgery.
A surgery means when
surgery.
The chest is open and
Yeah.
the surgeon's working on the heart
Right.
through an open chest.
Right, so this is major open heart surgery.
Whereas the other things you talked about did not involve any surgery. It was just done through a needle or a catheter.
Correct.
Okay.
Those are what we would call non-invasive or minimally invasive. Probably minimally invasive is a better phrase to use as opposed to not. But this surgical type of procedure is during open heart surgery. For example, if one is there for a mitral valve replacement, a heart valve replacement, they have atrial fibrillation because that often comes hand in hand with mitral valve disease. That the surgeon at the time of the procedure can do what's called a maze procedure, M-A-Z-E, where they can, again, almost like cautery or burning, or just really alter the architecture of the atria to disrupt the electrical circuit that is present to cause the atrial fibrillation. And again, it's not the greatest procedure in the world, but they're there, and they just do it sometimes. I don't think anyone is going to a primary maze procedure alone to treat atrial fibrillation. That would be a bit extreme, I think, to do an open heart surgery just for the atrial fibrillation, especially when we have these catheter-based techniques now. But yes, a maze procedure is available during surgery. And there are all sorts of other experimental things being done at different centers across the country where one could have a minimal open scar here on the side, and cryotherapy or freezing therapy might be delivered, or laser therapy, and these are all experimental things that are being done. So who knows where that's going to go.
Okay, great. Very good. So I think that you've helped us understand what treatments are available. What can an individual do? Is there anything that someone can do to help themselves in this regard?
Yeah, I mean, there's certainly things that people can do about, and they're common, general health maintenance type of thing: eating well, avoiding caffeine, avoiding chocolate, getting good rest, easy to say, but avoiding stress and fatigue, and that's easier said than done, obviously. Exercise, cardiovascular fitness helps. Reducing one's salt intake, which may help with reducing your fluid retention if you're prone to congestive heart failure or high blood pressure. Alcohol, if that's an issue for you, avoiding alcohol can make a big difference. Quitting smoking, especially if you've got concurrent lung disease as well, it can, and that's playing a role in the atrial fibrillation. So these are things that you can do yourself to help. Certain types of over-the-counter medications, many of them largely removed from the market with stimulants in them, or workout supplements with stimulants in them. Avoiding those would be of use. So those are some of the basic things you can do for yourself. One thing I forgot to mention before that I think is worth mentioning, that's exciting certainly, is that when talking about Coumadin, that there's a lot of work being done and research being done, and in fact research that we've taken part in our office, looking at newer or alternative agents to Coumadin. The downside to Coumadin being that there's a need for constant blood tests and monitoring. It's a real drain on patients, I guess, if you will, for lack of a better phrase. And so there is some emerging data to suggest that there could be another agent out there that is actually perhaps even better or more effective at reducing stroke, and possibly safer as well, with diminished bleeding complications. So it's a real exciting thing to think about. And what was fun about it, too, is that we were one of the sites taking part in some of this research.
Okay, great. So. Is there Is there anything that you would suggest a person do once they have the established atrial fibrillation diagnosis, they've had the initial evaluation, and they are not having much in the way of symptoms? Rate seems to be well controlled on the medications that are used. They're on the Coumadin. Is there anything else that needs to be done, or do they just need to be periodically followed? Or is that pretty much what's the story at that point?
I think that's, unless I'm missing something that you're getting at, I think that's pretty much the story. I mean, I think you're asymptomatic, heart rate's under good control, your heart's structurally normal and doing okay, your blood's thinned. You still need to be followed and watched and have EKGs performed periodically and be examined physically and certainly notify your physician of any change in symptoms. But yeah, I think that's and that's the vast majority of people are in that state where they're well maintained. But certainly one if they become ill from something else, for example, you get a pneumonia, for example, that strain or stress is often a time where the heart rate takes off on you. And the heart rate itself, in and of itself, in the setting of a secondary to an illness, it's not the major problem. It's often a secondary phenomenon, a strain from a secondary illness. And that happens all the time. We see people in the hospital who come in with a pneumonia, and their AFib takes off and goes fast. And we just get it under control, and then they get back to their steady state and do fine again.
The thing that you did mention, I just want to clarify, is that you said the Coumadin is the standard treatment currently, that there may be some newer things on the horizon. We're here in 2009, and we don't know what will happen in the subsequent years. But is there, if someone can't take Coumadin, or just Coumadin is something that they don't want to deal with, do we have a good alternative or not?
There are alternatives. There's aspirin, for example.
Would you consider that an equivalent to Coumadin?
No. So that's the main point to make, is that it is not equivalent. It's better than nothing, certainly, but it's not equivalent. And if one is, when we talk about all these different risks, very low risk, aspirin is actually probably the preferred choice, because there is a downside to Coumadin, certainly, with a bleeding risk and such. So, but when one has the significant risks, Coumadin by far is the drug of choice. But right, you said some people might not want to take it, et cetera. Then aspirin is a second line type of. But
clearly
therapy.
Not as good.
Inferior.
It's clearly inferior to Coumadin.
Yeah, absolutely.
Okay, great.
All right.
Well, thank you very much. Dr. Sunny Srivastava has now done a beautiful job summarizing an important medical problem called atrial fibrillation, which we see frequently in the community, both in our offices but also in the hospital. This medical problem is one that has real issues of concern because it is a major contributor to the cause of strokes. And strokes, of course, are debilitating. They can cause death. But the thing we worry most about is that they can cause severe lifestyle changes, and patients go from high levels of function to lower levels of function because of the consequences of the stroke. So we thank him for bringing us up to date on sort of the advances in this field, the state of the art, and we would recommend that patients think seriously about it if they have this problem, to get appropriate care from their medical doctors or cardiologists. So for now, we're going to sign off and say thank you for joining us again for another edition of Matters of the Heart. I'm Seth Belazarian for Haverhill Community Television and Pawtucket Medical Cardiology. Thank you and good night.